I am substituting tonight for Rebecca Berman. She's not available. However, I'm happy to moderate tonight. Glenn
We're
Grossman
glad to have you. Thank you.
Oh, thank you, Glenn. Glenn Grossman is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and UNC. He has been involved in epidemiology forecasting and advanced analytics with Bristol Myers Squibb, Sanofi, Novartis, Medicare, Medicaid, Veterans Health Administration, Military Health Service, CDC, and other programs within the United States and abroad. All views expressed today are his own. I have an assistant tonight, and her name is Danielle Berman. And if you have any questions, please send it to chat and private message Danielle Berman, and she will send the questions to me. Thank you very much. Okay, Glenn, it's all yours.
All right, great. Let's take a look at where we are in the world. Give me 1 second as I share my screen.
Okay. Here's what you need to know.
All right. Arlene, I'm just going to mute you for a second. I'll keep you unmuted in case you need to say anything. But
okay.
Great. All right, let me share my screen. All right, so where are we here? All right, so we are now looking at confirmed cases. Let me jump to where we are in the United States.
I hope.
No, we're not.
All right, give me 1 second. Arlene, I'm going to mute you. So you're just going to have to unmute yourself when you are ready to talk. Okay. All right, so what are we looking at here? So we are continuing our sharp decline, and this decline is much sharper since previous weeks or since previous surges rather. If you recall, back in the first surge, it took a long time to go back down, and in the second surge, it took a long time to go back down. But this surge, we are dropping very fast, which demonstrates two things, I think. One, we could have gone down much faster in the previous surges, and two, in this one, we are going down fast, and it shows the power of masks, wearing masks. So universal mask wearing as close to that as possible. We're wearing a lot more masks now than we were back in the first or second surge. Social distancing, we're doing quite a lot more now than we were then. And so I think those kinds of things made a big impact. The biggest thing is mobility. After New Year's Eve, there weren't a lot of events in January. There weren't really many holidays, religious holidays or whatnot. And so a lot of people just weren't hanging out with each other. And so as a result, that's probably the biggest single reason for the drops we've been seeing. It's just there's been a tremendously reduced amount of social interaction. And so we see a huge reduction. There's also seasonal, and this is typical for what we see most years with other seasonal respiratory diseases. So like flu, colds, and things like that. We were all expecting we'd see a peak around then that would slowly come down, but I don't think anyone was expecting it would be coming down so fast. So we're really glad about that. In addition to the cases going down, the hospitalizations are going down, which means that it's not just a testing decrease, because there was a hypothesis a few weeks ago that, well, maybe it's not that the cases are actually going down, it's just that the testing is decreasing. There's been a lot of snowy weather in much of the country, and so maybe that was explaining it. Nope, this is real. Hospitalizations are going down, and now we're also seeing a dramatic decrease in deaths in the United States. So this is reflected in when you look at hospitalizations. So if we look at the rates per state, which is coming up now, you'll see that a lot of states have gone back from being in the black where they were to blue. And blue is much better. That's where we want states to be, where the states are out of the danger zone. A lot of these states that are still in black, like New Jersey, New York, some of these others, it means that the hospitals are still overextended. And so we need to get the cases down there in the hospitals because they don't have as much surge capacity if there's other things that happen. For instance, if there were some other emergencies, some other driving accidents, for instance, some or massive injuries that would require a lot of the hospital's focus, they don't have as much spare capacity to address that kind of stuff. So we need to get those down. But most of the country is in great shape right now, so we're looking good. That's enough for now, even in the United States. We're doing really well in the United States across the board, across every state. So when you look at this one, when you look at the week of the peaks, this shows when each state had its peak, had its highest number of cases, so its peak. And you see Virginia was the last one to have its peaks surge here, and that was already over a month ago. So there have been many weeks where it's just been decreasing in all the states. All right, now I'm going to come back to global. Okay, so here's how we're doing. I'll get the map out. So here's how we're doing globally. You can see that the United States, even though we're coming down, we're still in the red when you compare ourselves to a lot of other countries. Some countries in Europe are doing particularly bad. So some of the Eastern Europe countries are not doing so well. Estonia is doing worse than I had thought that it was. But you can see that much of Europe is still struggling. Other parts of the world, South America. So this is really interesting because South America, it's summertime there now. And so this is a seasonal virus. We were not expecting there to be so much spread in the summer. And the reason for this is largely the Brazil variant that's going. The Brazil variant has escaped, largely escaped. There's still a little bit of immunoprotection, but largely escaped the vaccines. There's not a lot of vaccination going on in South America yet, but despite that, it's also escaped natural immunity. So people who are previously infected, so for instance, there were some cities in Brazil where they thought they had reached herd immunity. 75% or more of the people in Brazil in some of these cities had already been infected by this past November or so, and then a whole new surge happened, which demonstrates that this idea of herd immunity doesn't matter. There's no herd immunity with this disease because new variants are emerging and people lose their immunoprotection over time. So that's what's going on in South America. We're hoping now with the vaccines that will protect us to a larger extent from a lot of these variants that are going around, which we'll talk about a little bit more. And we might see a need, say in early fall or so, to get a booster shot, another booster shot for all the vaccines that will protect us from the Brazil variant, the South Africa variant, and some others that we're looking at now. All right, when you look at the totals that we're looking at, let me switch this to cumulative and go back to chart. I was looking at this earlier because Israel is in the news with COVID because of their amazing vaccination rollout. But what they really failed to do is really reduce the spread through non-pharmaceutical interventions other than vaccines. And so you can see here, there's still a tremendous amount of spread continuing in Israel. It's even worse than the United States. Even to the point when you look at the recent 7-day average, Israel, even with all their vaccinations that they've done, still have more cases per day than the United States. So they're almost twice as high as what we're looking at with the United States. So it's a good thing that they're vaccinating so fast, but they really should have done other things. They should have shut down to a larger extent earlier on. When you look at deaths, the infection fatality rate varies across countries, and we'll get into that a little bit later tonight with one of the questions. But you can see that even though the spread is different in various countries, the death numbers are higher in some countries versus others. So for instance, United Kingdom has quite a lot of deaths. The United States also, we still have quite a lot of people dying, but that's a lot more than in Israel. Israel has a lower infection fatality rate. There's a bunch of reasons for that. The biggest one here is probably the people being infected in Israel tend to be younger, and younger people have a much lower risk of death. But there's some other reasons as well. All right, that's it. Let me switch over to vaccinations, because that's the real story that a lot of people are interested in now. All right, so here's a map of vaccinations in the United States. You can see that there is a lot of variation. So you can see that in some states, for instance, West Virginia is doing well. 16%, over 16% of people in West Virginia have gotten at least their first dose of the vaccine, and almost 10% have gotten the second dose or fully vaccinated. In contrast, when you look at New Jersey, around almost 6% are fully vaccinated, but some states in the in other parts of the country, for instance, Texas, under 5% are fully vaccinated, and only around 11% have had at least one shot. So there's wide variation. In fact, when you look down here, that's what I was looking at just a little while ago. So the United States average is right around over here. It's hard to hit on. So it's around 63 million doses given in total. That's 19 doses given per 100 people, but a lot of people have had twice. But if you look at the total doses administered, you see that Alaska is doing amazingly well. They're way up in the lead in terms of getting the vaccines out, but that some states are not doing quite as well. So Alabama is not really not doing well relative to some other states. And so the average across the United States, I think part of this is a data issue. We've been doing so well at increasing it. And so I think that this decrease that we're seeing is that the data is not coming in the same way. So I don't really trust the recent data over the last week or two. But basically, we've been averaging around 1.5 million doses given per day. And so that's still increasing. So I'm expecting us to hit maybe 2 million doses per day within the coming weeks, depending on what this data looks like. We'll see in another week if this is a data issue or if we're really not accelerating as fast as we would like. All right, globally. So globally, around 50%. So in Israel, 50% of Israelis have received their first dose. In the United States, around 13% of people in the United States have received at least one dose so far. When you look at, and so you can see that there's wide variation. Israel, United Kingdom, Bahrain, Chile are doing the best. So Chile, South America, I mentioned earlier, wasn't vaccinating as much. So for instance, when you look at Brazil, they're only at 2.7, but Chile is doing quite well here in terms of the first dose. When you look over here at where am I going? I'm looking at the second dose. How many people have been fully vaccinated? A third of people in Israel have gotten both doses at this point, which is extraordinary. Where only 5% of people in the United States have gotten both doses. So, so we're still, a lot of the world is still waiting to get the second dose. All right, let me turn it back over to you, Arlene.
Okay. Okay. First, Sandy has a question, and her question first is, do you anticipate getting boosters in the fall being as difficult as it is for so many now?
I don't think it's going to be as hard. The biggest question is going to be how fast the rollout is. With the flu vaccine, it's usually not very challenging to get it, and that's for a variety of reasons. One of the main ones is that people typically get it over a few months. So some people might start getting it, I don't know, maybe as early as August, maybe early September, and then maybe continue getting it through October and November. And so as a result, it doesn't feel like there's this major crunch to go and get them. Also, as a result, because you can distribute them over a much longer period of time, we don't feel sort of compelled. Whereas with coronavirus, we might all feel compelled to get it the very first day. And there's no system in the world that logistically could support that kind of thing. So if we can get it at our physician's office, then it'll probably be like a flu vaccine. I think maybe there'll be some logistical constraints just because we're used to giving vaccines out over weeks or months, typically for like a flu vaccine booster shot, not over like a day or a few weeks. So that could be the challenge. But in general, I don't think that we're going to have much logistical constraints in producing the booster shot if we need it. Because at that point by fall, we're assuming that the vast majority of Americans will have received their second dose by that point. So there should be a lot of extra capacity to begin doing booster shots if we need them. The other thing is they probably still need to look at the dose. It may be the case that if you get another booster shot in the fall for these variants, maybe you don't need the full dose that we've had. Maybe you only need half a dose, in which case they could give out twice as many vaccinations with the same amount of material. So I don't know. I'm not too worried about that. The biggest question is going to pivot away from the United States in the fall to really vaccinating around the world as rapidly as we can, because that's going to help us here in the United States protect from having new variants emerge. Because if new variants emerge that can break through our vaccines, that's going to be really problematic. So it's going to be much easier for us and much cheaper in the long run for us to do a global vaccination campaign than to risk having new variants emerge suddenly in random times of the year and then having to go into shutdown again. In fact, one thing, I don't know if this was a question, but I can just pivot to this real quickly. There was some interesting news today, or rather this past week, about the Pfizer and the Moderna vaccines. As you mostly know, previously they had to be stored at ultra cold temperatures. And that's one of the main reasons that you couldn't go to your physician's office to get the vaccine, why instead you needed to go to a big facility or a hospital or some other place that had the logistical capability to store the vaccines at this really, really cold temperature with these specialized freezers. But what they just found, so Pfizer, here's a press release from Pfizer, is that long-term, say when you're looking at over a month, it really needs to be in these deep freezers. But over a 2-week period, it still has sufficient stability that you can keep it in a regular freezer. And in fact, they're suggesting that you might even be able to simply keep it in a refrigerator for 5 days maximum. So if this gets through, I don't know if it's officially been evaluated by the US FDA yet and been approved, or if it's still just been demonstrated with their clinical trials or in the labs. What this will mean is a dramatic impact in terms of where we can get the vaccine. Because if this is true, then and you can just store it in a regular freezer, then a lot of physicians' offices have regular freezers, or if we're talking about a refrigerator here, that it's good for 5 days in a standard refrigerator, a lot of physicians' offices have some capacity for a regular refrigerator. So this would dramatically alter the distribution of these vaccines and make it much, much easier to get. Remember, one of the main constraints right now is not the number of locations giving vaccines, it's the number of vaccines available. There's just not a lot of vaccine to go around. So it's been really logistically a constraint, but also logistically makes it easier to do it all at these large facilities. But once we reach this point where a lot more people get vaccinated, we're really going to make it easier where we can vaccinate within physicians' offices. I think that's going to make a big difference. And particularly going back to this idea of if we need another booster shot in the fall, then this would make it much easier where you could just probably go to your regular physician's office and just get it there.
Sounds good. Okay. Glenn, can you update us on variants spreading in the US?
Sure. So let me go to this website. So before I go onto that, let's talk about how much sampling is being done. So at the end of last year, in the end of December, we were only doing genetic tests on around 1 out of every 333 people who got COVID-19, who is a positive test for SARS-CoV-2. And so that was very, very poor. And a lot of other countries, they were doing much better. Since Biden came into office, that was one of the first things that his team did, was to try to really rapidly increase the amount of sampling we're doing, the amount of genetic screening we're doing for all of these variants. We're still not there yet. So we're already the end of February. The red is what they plan to do and the yellow is what we've done. The red looks very optimistic. So I hope we get there, but at least we have a plan to get there. They had no plan back before the inauguration. So we're slowly increasing genetic screening, which is going to be great. because it's hard for us to even know where we are. Right now, this is how much screening is going on. This doesn't tell us where the genetic variants are. It only tells us where they're even being tested for. And you can see that in some states, they're doing a lot of testing for these genetic variants, whereas in other states, they're doing hardly any genetic testing for these variants. And so it makes it hard to even know. Like if we look at maps that I'm about to show you on what the estimate is of the number of variants across the United States, it makes it hard to interpret if we don't even know whether they're doing a lot of testing or a little testing. So here, this map is useful because it shows that some states are really doing quite a lot, whereas others are not doing very much. At a glance, you can see that across the states, some states are doing well. So for instance, New Mexico is doing around 1%. So 1 out of every 100 cases that come in, they're testing the genetics of it to see if it's a variant. In Maine, it's 1 out of every, it's 2.5 out of every 100. So they're doing well. Whereas you look at some other ones, I'm just glancing down here, Oklahoma, 0.04. So out of every 100, they're doing less than 1. It's really not sufficient for the genetic variants that are of such high concern that we have. In addition, there's a new variant that people are starting to get worried about. The new variant was previously called the Nigerian variant. Now there's a new one that's come out, and so that's what this is. Where it's typically calling it the A231 variant. It's not a variant of concern yet, but it is sort of, what are they calling it? A lineage of note. It's a variant of note that we're paying attention to because it is starting to spread a little bit more. It does have some of the mutations that we found in the other ones, so South Africa and in Brazil, that makes it more resistant to the vaccines. So we are looking at this more. It does exist in the United States at this point. It also has been found in Denmark to a large extent, United Kingdom, Nigeria, US, to a lesser extent in Canada and Africa and some other countries. And so this is something that we're starting to look at as well. B1525 is another one, but we are, these are ones that we're starting to look at. The A20, or rather, this was not the A23 one, the B1525. I'm sorry, that was the Nigeria one. And again, this B1525 is the one that has this mutation that makes it more resistant to the vaccines. We're also looking at the A23 one. Both of these are lineages of note. They're not currently what they're calling variants of concern. So they're not as concerning as South Africa, Brazil, or UK. All right, one other thing. So let me just switch to this. All right, so right now, the biggest variant of concern in the United States is the UK variant. That's B117. This is spreading pretty rapidly. We're estimating it's doubling around every 10 days. But because our numbers are coming down so quickly, I can come back here for 1 second. So because our numbers are coming down so quickly, the UK variant is still a little hidden because it's a lot smaller than the numbers we're seeing here. So at some point, the UK variant is going to become more common. And so what we're expecting is that at some point, this is going to flatten out. And it's still unclear whether it flattens out and stops decreasing, or whether in addition to flattening, it starts to increase again. That's an open question. It all is going to depend on how well we continue wearing the masks, social distancing, and getting the vaccines, and doing the other things that we're doing. But that's the huge question over what the next few weeks look like, is whether we continue at this pace, flatten out, or start to increase again. And if we start to increase or flatten out, that will almost all be due to this UK variant that we're talking about, which just went away. There it is. The states that are right now have it the most are Florida. You can see this is in blue because Florida is really not doing well here with the UK variant. It's starting to spread very much. California, it's starting to spread quite a lot. And also, up in some of the northern states, including Michigan, it's starting to spread a lot more. In New Jersey, New York, it's more than it has been. It's here, but it's still at a much lower level, because in New Jersey, we're looking at 50, New York 70, but in Florida, we're looking at 433. Again, these are not cases. These are just people that were genetically, where the virus was screened. So each one of these cases represents a lot more actual people that we just don't know where they are because they weren't screened. And so this is just a sample. All right, so now we have this. That's with the variant. Was there anything else I wanted to talk about? Oh, so the website that I was just looking at in terms of the concerns, you can see that the UK variant B117 has spread globally. The United States has it a lot. That's what I was just showing you, the UK variant. It's also spreading a lot in South America. That's part of the reason why, even though it's summertime there, they're still getting hit really hard. The UK variant is to blame there. You can also see in parts of Asia, much of Europe, and some other parts of the world also, the UK variant is out of control. The B1351 is the South Africa variant. You can see here that it's really hit Southern Africa quite a lot. It's hit a little bit of Europe. You see some countries are being affected, but you can also see that the United States is also being hit somewhat hard, and it's starting to spread. Not as fast as the UK variant in the United States, but fast enough that it's really something that we're going to be paying attention to. Again, the South Africa variant here is worrisome because this is one that can get through the vaccines, and so it can get through that. The other one that we're looking at here is P1, that's the Brazil variant. This can also get through the vaccines. You see that this is also more common in South America, Mexico, and then to a little extent, it's already spreading in the United States, Canada, parts of Europe, and parts of Asia. All right, then the lineages of note that I just said, they're not as bad as the variants of concern that are up here, but they're also spreading to a degree. But the United States, we're getting everything. We're not doing enough screening of the virus coming in, and so as a result, people are just coming in, and any variants that emerge anywhere in the world, we're pretty much getting it in the United States. Hopefully that won't be the case. I showed you this really ambitious curve. Once we start doing a lot more genetic screening in the next month or two, hopefully we'll be able to screen out new variants much more rapidly before they really start spreading around the United States. This is something I wish we had been doing 6 months ago, but we weren't, and so now hopefully we're in a new direction now. All right, Arlene, back to you.
Okay, we have a question from Rachel, and Rachel asks, how would the booster shot impact those who have yet to be vaccinated? Would the booster be different from the initial vaccine, and thus that would not compete with people who just want one dose?
Oh, that's a multiple part question, but that's a really good question. All right, so the first question is, if you haven't yet received the initial vaccine and a new booster shot comes, could they just mix it in and then we just have the regular vaccines without having to worry about getting a third booster shot? I don't know if they've evaluated that. Most likely, they're probably going to want to make it as logistically simple as possible. So they would probably end up restricting it to only 2 doses for everyone. But people who have already been vaccinated, they would need a third one. In terms of, so I brought out a list. Let me see if I can bring this up real quickly. So in terms of the vaccines, not everyone, I think, is looking at the new variants to the same degree in terms of a booster shot. Let me see. This is pregnancy. This is pediatric. Contingency plans for new variants. So Pfizer isn't yet developing a booster shot, the last that I heard. Moderna is developing a booster. AstraZeneca is developing an updated vaccine altogether because their original vaccine is not doing very well in South Africa. So they're just going to replace their vaccine as far as I can tell. And then Novavax as well is going to be also doing an updated vaccine. So a bunch of these vaccine companies are probably just going to replace rather than require a third dose, unless people have already been vaccinated, then it would be a booster.
All right, just one clarification in terms of like logistics and administration of it, like, is it the same process whereby if they're starting to have to give boosters out to people that have had initial vaccinations and people haven't even had their first or second doses, like, is that going to be competing supply or demand of resources, I guess?
I don't think so, because we're vaccinating so rapidly. So we're vaccinating roughly 1.5 million people every day in the United States, at least. And so as a result, we only have probably, what is it, like 250 million people before we even get into kids. So that means at the rate we're going, 200 days, we're going to hit well over 200 million people. And so that's before fall. So by fall, we're going to have everyone who can be vaccinated will already be vaccinated. So by the end of summer, we're really going to be focusing on people who have vaccine hesitancy, I think, at that point. I think almost everyone who wants to get vaccinated will be able to get vaccinated by the summer. So when we're really talking about these booster shots for the variants, we're probably looking more likely into early fall, the typical flu season, when we have the seasonal variation. We want to get ahead of the curve there. And at that point, I think almost everyone will have gotten their first vaccine set, the full course who wants it by then. So I'm not too worried about that.
Okay. How do we know that the SARS-CoV-2 mutations are evolving as opposed to just being random?
That is a good question. Let me see if I can find it. Nope, that's not it. All right, so we've talked about evolution a bunch of times before. So evolution is really interesting. A lot of times you don't need to have, let me pull out this chart that we've seen previously. Here it is. So we've looked at this chart previously, where it's this question of you have sort of changes over time, where you might start with one variant, and then that variant sort of develops new branches of mutations. And so over time, you see a much larger diversity of variants that all started from the original virus. And so what's interesting is that some of the mutations, like if you look at the different colors here, some of the mutations that might confer special abilities on the virus. So maybe it makes it more likely to spread, or maybe it makes it more likely to persist in the body. So the immune system has a harder time addressing it. Some of those things that address it evolutionarily, that make it more evolutionarily successful, can evolve independently. So even though the mutations might have taken it in one direction, the mutations might continue happening, and then you might end up with variants that, even though they started in different places, they converge back to having similar types of mutations or similar types of behavior. That's one of the reasons why when you look at evolution in species, you a lot of times see eyes that evolved in lots of different ways, where it wasn't one organism that was the great grandfather of all organisms with eyes. Rather, you see it has evolved in lots of different ways because eyes are very useful. It's the same idea with evolving legs or evolving ears or evolving other types of strategies, is that if it's useful, then the mutations might converge. And sometimes they're the same type of mutations, similar genes evolve, and sometimes they're completely different genes and completely different things that are making the behaviors or the whatever the organ is, that it's similar organs that evolve. In this case, what we're looking at, if I can come back to where we were here, is that what we're finding is that there's a bunch of variants that are converging. So they weren't a great grandfather that they all came from. I mean, originally they all started in Wuhan. Now the Wuhan version, the Wuhan variant, doesn't even exist anymore in the wild because all of these other grandchildren of the variants have now superseded it, have become so common that they're the ones that are much better at replicating. And so what we found is that there are a lot of distantly related variants that are having similar mutations. So the mutations process itself is random, but the question of whether the certain mutations are selected is not random. That's based on how well the virus is able to replicate and spread. And what we're finding is that there's a lot of convergence. And so the spike protein, for instance, is even though there's lots of different variants, they are starting to be very similar in the types of mutations that we're seeing. And that's why when you look at the South Africa variant, the Brazil variant, Nigeria, other types of variants, even though they didn't come from the same source, perhaps, they are still converging in terms of a lot of these mutations that we're seeing, because it's the human body itself that's selecting the ones that are harming us the most, essentially, because those are the viruses that are having an easier time spreading and surviving despite our best efforts with our immune system. All right, next question.
Okay. Can you update us on the current sum of evidence for treatments for COVID-19?
Sure. So over the last year, there have been a lot of different therapeutics that have been looked at. Some of them have some evidence, some have no evidence. In fact, the vast majority have no evidence. All the yellow ones here have shown, after all extensive clinical trials, that they have really no impact. When you compare the treatment group to the control group, there's virtually no impact. The lines, the dashed lines, or rather not dashed, the horizontal lines show that we don't have a lot of certainty, whereas the solid ones show that we have more certainty. The big takeaway here is the corticosteroids. We talked about this months ago, I think even early summer. Dexamethasone was the first one, but other corticosteroids have been shown to have really important protective effects that protect against death, against being on a ventilator, protect against other things. So the corticosteroids are important. There's some other drugs that have been found to be important. So for instance, some of these that we're looking at here have various effects in terms of modulating the immune system that we're looking at here. Remdesivir, although it was given an emergency use authorization, it turns out not to be very effective. So maybe it's slightly more effective than control, but really not very effective. Other things that we've looked about, that we've talked about over the course of the year, so teclizumab, how do you pronounce this? Tocilizumab, which is it's used, I think, for rheumatoid arthritis, or for another mAb, so it's a monoclonal antibody that's used specifically to tamp down the immune system for some diseases. This has not shown any efficacy in reducing the immune response to COVID-19. A bunch of other things that have been looked at turns out not to be very effective. Here's hydroxychloroquine, which President Trump put so much time investing in communicating hydroxychloroquine. Now, after numerous clinical trials have been done, we know hydroxychloroquine does not improve the disease. It does not make people better in any meaningful way. Whereas after all these studies have been done, we now know a bunch of other drugs are beneficial. So that's good. A lot of clinical trials are still ongoing, but the vaccines are really among the best. The other thing that's here, or it's not described here very well, are the monoclonal antibodies. The monoclonal antibodies have shown to be very effective under emergency use authorization for if you get them early enough. So if you get them within a day or two of when you're first infected, they're like a miracle drug for a lot of people. But if you wait too late, if you wait until a person already starts getting symptoms or already starts getting severe symptoms, then by the time someone has severe symptoms, it might even make it worse. It doesn't have any benefit at all. So that's for people who have not been vaccinated yet. Still something to keep in mind is the monoclonal antibodies. In fact, one question that came in, I'll just jump to this real quickly, is a new monoclonal antibody discussion. So we've been talking about monoclonal antibodies. Monoclonal antibodies, we've been talking about all these months. There's making a new version that they've been studying in clinical trials. And these are called long-acting monoclonal antibodies. So whereas the previous monoclonal antibodies would probably persist for maybe a couple of months, we're thinking maybe as much as 3 months after someone's injected, the new ones are expected to last 6 months to a year. And this is a game changer because among people who can't get the vaccine, say someone who's immunocompromised, say they're a cancer patient, or someone who has other illnesses where they're immunocompromised in some way, or maybe taking immunosuppressive drugs, that might impact things. These people will now be able to get a long-acting monoclonal antibody even before they have symptoms or even infected. Because if it lasts a year, then you might as well just get it as soon as it's available, and then you're protected for a full year. So I suspect if this gets emergency use authorization and if it becomes approved, I suspect that this might become standard of care for a lot of patients who can't otherwise get vaccinated, who are at high risk. And so this is, I think, going to be game changing as well. So this is going to be interesting. So that's something on the radar.
That sounds very hopeful too. Okay, Should people who are already infected get the vaccine? And do they need 2 doses?
That is a really good question. So here is a study that was done on this. So as it turns out, people who are previously infected, who are naturally infected, this study demonstrates that when they get the first dose of the vaccine, they have the same amount of antibody as people who get the second dose of the vaccine who were not previously infected. And so as a result, right now, the CDC is still recommending that everyone, regardless of their infection history, gets 2 doses with the vaccine, because that's how the clinical trials originally were done. But if we're now interested in vaccinating more people as rapidly as possible, then if someone was previously infected, it might be a good strategy to give them 1 dose because they already have then the maximum benefit instead of having a second dose for those people. It's still something being investigated, but this is really compelling evidence. So it might be something that we see in the coming weeks where we hear a change that they announce.
Okay, very interesting. Thank you, Glenn. Okay, what is the current best estimate for the infection fatality rate? Has it changed between when the CDC was run by Trump versus when it was being run by Biden?
So this is a very interesting question. And so let me bring us back. So the infection fatality rate, if you recall, this is among everyone infected, what percentage of them ultimately die from COVID-19? This is different than the case fatality rate, which says among everyone who has symptoms, what percentage of them ultimately die? That's the case fatality rate. Then that's a different question even than what we're looking at now, where we know that there are successful treatments and successful vaccines. And so the infection fatality rate has come down just because we have better treatments that work. So by this past summer even, the infection fatality rate had dropped by almost half when you include a variety of reasons of what happened in the summer. And then also by fall, we had a lot more drugs available that we could pull from that we knew were effective. And so this probably reduced the infection fatality rate by around half. But if you recall, there was this major controversy back in March or April. And the bad actor, the guy who really was not doing well here, was this guy, John Ioannidis. He originally estimated that COVID-19 would only produce around 10,000 deaths in the United States. And we know that that's not true anymore. We very quickly realized that that wasn't true in the United States. So he kept on lowballing it. He was using very, very bad methodologies, but was reporting it as if it were good methodologies. And so, for instance, he was picking really terrible studies that were not representative. They did not meet even basic criteria for studies that you would include in a meta-analysis. And he was including them. But what makes him interesting is he had the ear of President Trump. And so as a result, President Trump had him assemble a group of other people who agreed with him, who were not representative of mainstream epidemiologists. And by the way, John Ioannidis before this had an amazing reputation. He was a guy who used to criticize other scientists for having poor methodologies. And so he developed a name for himself where he'd criticize the methodologies of other scientists and then would replicate it and then show how they were wrong. So he developed a name. So this was totally astonishing, totally out of character, but he was persistent in this. And so he got the ear of President Trump, even though these studies were, at the time, epidemiologists around the world were scratching their head and saying, what the heck is this guy doing? This is so out of character for him. But yet he continued doing it. He did it. And what ended up happening was, so this one guy who was in Australia, Mayerowitz Katz in Australia, suggested that the infection fatality rate was around 0.64% before we started getting these treatments and other things. Ioannidis suggested it was around 0.26%, so much less than half. And he was saying that he thought, based on a variety of factors, that it was probably not much worse than the seasonal flu, which we know by now is very wrong. And so he was laughed out at the time, but he had the ear of President Trump. And so therefore the CDC was using his assumption. The CDC updated it, I think it was the middle of July 10th, I think, is when they updated it to use Meyerowitz's cats. That's what they're updating and using now. But again, it's gone down some since then because of the treatments. But let me just go, because they just published, this group, Meyerowitz cats, just published a really in-depth analysis, sort of the final, it punctuates the argument. And so these are the key things that are wrong. I'll just spend a few minutes talking about this because it's just so interesting. So the original study that Ioannidis did, one of the problems that he had was that a lot of people in the study, they reported how many people were sick and they reported how many people died at one point in time. But the problem is a lot of people who ultimately died from those sick people didn't die for many days or weeks after the study was over, because they stayed in the hospital and then ultimately died. So as a result, the infection fatality rate from Ioannidis showed that there were much less people dying. Whereas when you look at it over time, and or back then, if we had corrected for those things and sort of thrown out the convenient samples that Ioannidis had used, we would have had a much better estimate of all of the people that died. So for instance, this was pretty dramatic. If you looked at some studies, in fact, let me bring this to the top. If you looked at some studies, like Louisiana, there was a study where during the time point of the study, the midpoint of the study, only 477 people had died. But if you had collected data 4 weeks later, over 2,000 people had died, and 5 weeks later, over 2,200 people had died. So this dramatically changes this estimate of how many people died from the disease. This wasn't the only state. You can see there were a lot of places. Indiana, it went up quite a lot. You can see Philadelphia, it went from 456 people studied under the original study to over 1,500 people that ultimately died if they had just continued that study, instead of if they had just methodologically improved the studies that were used. So now this group, again, the Meyerowitz cats, when you look at it now, what he's done is he's taken all the best studies from all over the world during that time period. These are not studies that were published in August or November. These are all the earlier studies that we had this information back in February, March, April is when all these studies were generated, roughly that time frame that we're looking at, maybe some for May. And already at that point, when you do this thorough analysis, you can see that there's this really, really strong logarithmic scale of the infection fatality rate, where when you look at the age of people and you adjust for the age, there's a logarithmic growth rate. So if you look on the one on the right, this is more interesting in some ways. So here, what you have is the age of people. So age 45 to 85, and you see the likelihood of dying if someone's infected goes up on a logarithmic scale. So someone who is 85 years old without vaccines or without treatments or anything, this was the case back in March through May, they had roughly a 15% risk of dying if they were infected, and it continues going up at an accelerated rate, exponential rate with this logarithmic scale. And yet people under the age of 45, it's much less. In fact, when we look here, this is now the best estimates we have. For people 85 and over, the average is if one of them gets infected, on average, 28% of them, 28.3%, or a range between 21 and 36% of them will die. And so this is, the treatments, like I said, have brought this down some, but you can see the range that we have here. If you go down to 55 to 65-year-olds, it's still quite high. So it's 0.75%. So it's still under 1%, but it's huge. When you compare this to automobile fatalities, so car accidents in the United States or in England, which was they did, I'll look at the United States. In the United States, among 55 to 65-year-olds, there are 0.013% of people die in automobile fatalities every year, which is, you can see, is an order of magnitude. This is far, far more for COVID-19. Similarly, among people 45 to 64, it drops precipitously, but in particular, among people under the age of 45, you can see how quickly it drops. And just to punctuate this, among people under the age of 35, people in the United States at that age, under the age of 35, again, have around a 0.015% chance of dying in a car crash in a given year. And that is a greater likelihood than of dying from COVID-19 if they get infected from SARS-CoV-2. So again, people under the age of 35 are far more likely to die in a car accident in the United States than they are to die of COVID-19 if they get infected with SARS-CoV-2. So this is really important to know. However, people under the age of 35, particularly the ones aged 20 to 35, are much more likely to spread the disease. So we needed to make sure that they didn't get infected, because if they get infected, they're much more likely to infect these older people who then are much more likely to die. So if we were trying to prevent the deaths of these older people, then there's direct ways of doing that, but then there are indirect ways of doing that, and the indirect ways being to reduce the spread among the ones who are younger. One other thing I was going to point out here is this. So this explains 90%, the age variation alone explains 90% of the variation across countries. Italy, based on this one thing alone, you would have expected they would have had an infection fatality rate of 1.5%. In fact, it was almost 3%. It was 2.5 to 3% up here, very high. Whereas Netherlands, you would have expected it would have been around 1.25%, but in reality, it was less than 1%. And that was due to other factors. So for instance, in Italy, a lot of old people live with the young people. Another factor that might explain it is that when they were first hit, if you recall, the hospitals were overwhelmed. And so because of that, they had to send people home because there simply weren't enough beds. And at that point, people were being sent home to die, and they could have potentially been cured if there were more hospital beds, but they had a lot higher death as a result. So there is some variation associated with that. But one of the interesting things, and this is where I'll just end it here for the infection fatality rate, is that they were really critical against this guy, the Ioannidis, who I was just mentioning. They didn't even refer to him by name. They didn't even refer to his studies because they were so crappy in terms of the way that they were done. But they were saying that these small early seroprevalence studies were small non-representative samples in low areas of prevalence. So this is epidemiology speak for dissing this guy. It's crazy. It's done so professionally, and the words are so kind, but you can't say harsher things in epidemiology, like just calling someone's methodological approach just garbage. These are the terms you use. And then they said, by contrast, our critical review identifies key characteristics that are used to provide a reliable assessment of infection fatality rate. So basically they're saying that this guy was just unreliable. It's just, as epidemiologists read this and our mouths fall because, oh my gosh, can you believe he said this in an article? But for most people, you wouldn't realize like this was like a major diss in terms of the publication that this was just published. It was published in the European Journal of Epidemiology, a prestigious journal. All right, I think we have time for a few more questions.
Okay, Glenn, is vaccine hesitancy changing over time? What percentage of people are willing to get a vaccine now? How is Israel addressing vaccine hesitancy there? Is there anything we can learn?
That's a really good question. Let me come down. Oh wait, where did I put it? It's over here somewhere. All right, here it is. Nope, that's not it. Oh, here it is. All right, so vaccine hesitancy. So there are, what is this here? So basically around 6 or 7, I'll call it 7 things. Nope, 8 things. There's 6 here and then a few other things that I'll get to. 8 factors are really driving vaccine hesitancy: gender, race, ethnicity, age, education level, political party. So this is so interesting to me, that political party, but this is, I think, a remnant of Trump. because I don't think that we used to have this kind of vaccine hesitancy based on Republican versus Democrat. We did based on education, age, race, gender, but I don't recall party being such a big impact before. Family income also has a big impact on hesitancy. You can see across the board, vaccine hesitancy is reducing. So more and more people are willing to get the vaccine across all groups, regardless of family income, regardless of party, age, anything. Across all groups, people are more and more willing to get a vaccine. Among gender, women are trailing. They're increasing still over time. This last poll was from November. It's improved even more since then. The other two things, so I said that there were 8. The other two things that have become really important are urban versus rural. Typically, people who live in urban or suburban areas are more willing to get vaccinated versus the rural areas are having a hard time getting people motivated to get vaccinated. And also states themselves. What we're finding is that there's wide variation across the states, where some states, for instance, Massachusetts, 85% of people in Massachusetts are hungry to get a vaccine, whereas less than 60% of people in Wyoming are motivated to get a vaccine. So the states varies a lot. We're going to have to do more campaigns, more public health campaigns in these places to get people vaccinated. Interestingly, Israel is starting to roll out vaccine programs to get people vaccinated. And there was one that I found that's become somewhat common that's really interesting. And that's this one. It's in Hebrew, so I'm going to just translate just the general gist. Basically, they're announcing that they're having these nightly walk-in vaccinations, and anyone who comes to get vaccinated will have free pizza and free beer. And they're raffling off an iPad or other tablet to get people vaccinated. So always the worry in public health is whether you put a mandate out there and say, you must do this or you get a fine. And that's sort of sometimes called like a stick, hitting them with a stick if they do it, versus giving them a carrot, which is doing something like this, which is saying, you should come get the vaccine. We'll give you free pizza and beer. And so I'm hoping we do a lot of carrots in the United States too. Frankly, I like pizza. So I'm already planning to get the vaccine, but if they give me pizza too, I'll be very happy about that.
Okay, Glenn. We're going to just have time for a couple more. We're almost finished. Can you update us on the COVID-19 in children? I saw an article in the New York Times last week about multisystem inflammatory syndrome in children, MIS-C. Do we need to be concerned?
Yeah, so this was, if you recall, let's go back. So there was an article, I think it was just last week in the New York Times, it might have been a week and a half ago, that people have been contacting me about, oh, is this something we need to worry about? Basically, there's it's now called MIS-C, the Multisystem Inflammatory Syndrome in children. Previously, we had talked about this many months ago. At that point, we were calling it Kawasaki disease. It was very, very rare, but it caused this really severe syndrome in kids. And so there was a lot of concern about it. It was very rare. At this point now, we're tracking it tremendously. It's still extremely, extremely rare. But I'd like to spend a couple minutes talking about it because I think it's pretty interesting. If I can find it. Yeah, so here it is. So the CDC has this website here, the Multisystem Inflammatory Syndrome in children, the MIS-C. And so basically, there's a bunch of things that are interesting. So first, there are 2,060 that have been cases that have been identified since the beginning of the outbreak. So since February of 2020, 2,060. 30 of them have died. So when you look at the total number of cases in children, it's rare for kids to get infected, but this is extremely, extremely rare in kids. Let me look at some other things that have been found. So when you look at this by state, interestingly, you see that there is variation by state. It could be that there's just lack of reporting in some of these states for one reason or another, or it could be that there's something going on either among the distribution of people that live in the states or something about living in the states themselves. I don't know what it could be. For instance, there might be different weather patterns or different something else about living in some of these states that could sort of be a effect modifier that could influence whether someone who is a kid is more likely to get these severe symptoms or not. But there is this interesting variation across states that have been identified in terms of the diagnosis of this syndrome. There's a seasonal variation, so it's the same surge variation that we've seen across the three surges that we have. But interestingly, even though the first surge and the second surge were much smaller in terms of the total number of cases, so when we look, where am I looking here? So when I look here, you can see that the third surge in general for most people was far, far higher than the second surge or the first surge. Yet when you look at kids, which was back over here, they seem to have a pretty similar impact across the three surges. That's interesting. We don't know exactly why that's the case yet, but it's just something interesting that they found. Race, ethnicity, also something really interesting. So Hispanic people are much, much more likely to get it than white people or people who are Asian or other ethnicities. Asian people are much less likely to have this syndrome than other ethnicities. So for some reason, Hispanics and Blacks are much more likely to be diagnosed with this syndrome. It's still something we don't understand why, but there is variation and we don't understand why it is. We just know that it's existing so far. Gender, so for some reason, males are getting it much more frequently than females are. Again, we don't know why this is the case, but this is just something that's been observed. And by age, there's variation. So interestingly, people who are age, what is this? This is the middle one. So this is age 5 to 9, seem to be more likely to get it than people as they get older. So 10 to 14-year-olds are getting it at a smaller amount. 15 to 20-year-olds are getting it at a smaller amount. Similarly, as you get down in age, so less than 1 to 4, they're also 1 to 4 is a fair, but that's a lot. But you can see that the 5 to 9, for some reason, that's the age group that's getting it among the highest, this condition that we're looking at. As people age out of it, as they go through puberty and get older, it just becomes less common and it just goes away. It's just very interesting. I think that was it. So those are the things we found. We still don't know a lot about this syndrome. All we've been able to do is sort of describe where it's occurring and some things that might be predictive of it. But in terms of different treatments, that kind of thing, we don't know a lot about it still. But like I said, it's still very, very rare. So nothing for most people to be very concerned about.
Okay, I think we have one more question, unless there's something
Sure.
you'd like to cover.
No, sure. If
Okay.
you have another question, sure.
Okay. In other epidemics like Ebola, dead bodies are very infectious. Is this something we need to worry about with COVID-19? Are the dead bodies very infectious?
Yeah, this is a really good question. So that's a really good point. So with Ebola, it's what called a hemorrhagic disease, which means that it's a bleeding disease. So people who die from Ebola, they frequently die pretty quickly after they've been infected. And so they typically have a lot of the virus that's spreading in their body. And so typically the dead bodies are extremely infectious. Typically they're bleeding out in different parts of the body and they're very, very contagious. And so as a result, it makes it really hard to address the dead bodies. In contrast, with this disease, it's a little complicated. When I first put this together, what we found is that people who are contagious and die when they're contagious, the virus has stability and they are continue to be contagious up to 35 hours after they die. So these bodies with COVID, people who die of COVID-19, we still do need to be worried a lot of times that the bodies themselves can still be contagious. However, because we've gotten better treatments, we have gotten better at keeping people alive long after they were infected. And on average, what we found is that people with severe disease, if they've been had symptoms for over 10 to 20 days, they are likely to no longer be contagious. The one exception for this is people who are immunocompromised. So if someone's a cancer patient or is otherwise immunocompromised, then they might be contagious for months. In fact, the longest case study I found was that one person was immunocompromised, and they found that I think it was a guy. I think he was contagious for over 5 months. So it is something that is a legitimate thing, and that wasn't the only one. I've read other case studies where people can be contagious for months if they're immunocompromised. However, the majority of people with the severe symptoms are not immunocompromised. And so among these people, the vast majority of these people with severe symptoms who go into the hospital are no longer contagious after 10 days. And virtually every one of them, again, unless they're immunocompromised, virtually every one of them with severe symptoms is no longer contagious within 20 days. So they might stay in the hospital for a variety of reasons, but they're no longer contagious at that point. Additionally, they might still be shedding virus. So they might shed virus. So if you gave them a test, a PCR test or other kind of test, they would still trigger a positive result, but the virus is not viable. The virus can't replicate any longer, so they're no longer contagious. All right, so that concludes this week. I really appreciate you coming in for Rebecca this week, Arlene, and thank you everyone for joining us. Keep on bringing your questions in. It's always fun to work to answer them and to help in getting these answers out to everyone. So have a great week, everyone.
We really appreciate it. See you next week, same time, same place. Bye-bye.
Thanks. Bye-bye.